All right, good evening. You need to turn your mic on. You good? All right, good evening, everybody. Those present, so colleagues of the staff of the School of Dentistry, members of the dental fraternity of Trinidad and Tobago, and DDS students from the School of Dentistry here at St. Augustine. Those of you joining us online, welcome to this lecture by Dr. Sankar, who has graciously volunteered to speak with us this afternoon on oral manifestations of rheumatic diseases with an emphasis on Sjogren syndrome. We teach the effects of Sjogren syndrome to our second-year students, and it's a regular question in our final examinations. But those of us who are actually practicing and have actually had a patient with Sjogren syndrome know the desperation of dentists in dealing with this. So we hope for a very interesting lecture this afternoon, and thank you. Dr. Sankar is a daughter of the soil of Trinidad and Tobago. Though she left us very early, we still claim her as Trinidadian. So welcome to the Faculty of Medical Sciences, School of Dentistry at St. Augustine. For those of you present in the amphitheater, I have a brief emergency briefing. We all know that the University of the West Indies places a high priority on preserving your health and safety. So this building is equipped with a fire alarm system. And in the event of an emergency, the fire alarm will sound. There are no planned drills for today. So if the alarm sounds, we will treat it as a real emergency. And once the alarm sounds, please stay calm, follow the instructions from various members of staff and the UE Estate Police, which is at the door. They will direct you to the muster point, which is through this emergency exit door. Basically walk north towards the mountains to the car park, which is P1. Once at the muster point, remain calm and wait for instructions. Do not leave unless instructed to do so, and you will be given further instructions at that point after an assessment of the emergency has been made. In case of a medical emergency, please speak to one of our committee members, either myself or Mr. Leben, or the estate police personnel outside, and they will direct you to first aid facilities. So, thank you for that, for your attention. I will now hand you on to Dr. Kandi Narayan Singh, who will give the brief introduction to our speaker this evening. Kandi.
Thank you, Professor Smith, Director of the School of Dentistry. To the members of the dental fraternity, the academic staff, students, and interns of the School of Dentistry, thank you for joining us this afternoon. And to our colleagues joining us on live stream, both locally and regionally, it's my privilege this evening to introduce Professor Vidya Sankar, who is a proud Trinidadian. We are indeed happy that you made the time to talk to us, especially to our students, some of whom are on the brink of final examinations, on the topic of oral manifestations of rheumatic diseases with an emphasis on Sjogren syndrome. A little bit about Prof. Sankar. She received her Doctor of Dental Medicine and completed her general practice residency from Rutgers School of Dental Medicine, and then served as staff dentist in the infectious disease clinic. She then practiced general dentistry in New Jersey prior to earning her certificate in oral medicine from the National Institute of Dental and Craniofacial Research. She was a recipient of the Sjogren's Foundation Fellowship, received her master's in health science degree from Duke University, and is certified by the American Board of Oral Medicine. Dr. Sankar's positions included tenured associate professor and oral medicine clinic director at UTHSC San Antonio, clinic director of oral medicine and dentistry clinic at Brigham and Women's Hospital, co-director of the oral medicine and oncology clinic at the Dana-Farber Cancer Institute. She's currently division director for oral medicine at Tufts University School of Dental Medicine and program director for the Tufts University School of Medicine Oral Medicine Residency. Currently, she holds the position of president of the American Association of Oral Medicine and is a board member for the Sjogren's Foundation. Professor Sanka has nearly 50 publications in referee journals, as well as several book chapters, including chapters in Burkett's Oral Medicine. And I'm sure a lot of us would remember that was our Bible in oral medicine as students. Um, she serves on several international and regional committees, including the International Task Force for the Nomenclature and Classification of Sjogren Syndrome. Her major research interests include Sjogren syndrome, oral lichen planus, xerostomia, and oral mucosal diseases. So join me in giving a warm welcome to Professor Sanka. We look forward to your talk.
Sorry? That's fine. Thank you, Dr. Narayan Singh, and thank you, Dr. Smith, Professor, sorry. In the States, we call everyone doctor, and everywhere else we call everyone professor. But thank you both for allowing me to come and speak to you all. As they mentioned, I'm Trinidadian. I was born here, but I was 3 years old when we moved to the States. But I have tons of family here, and I've come back every few years to visit all the families and friends and everything. And I just never, and every once in a while I would think, why don't I come by, see the folks at the dental school, see what the dental school is all about? And it just took me this long. So I apologize that it's taken so long, but I'm really happy that you're allowing me to come to speak with you all tonight. Sjogren syndrome is very near and dear to my heart, and I'll tell you the reason why. Mostly it was because it was the easiest if I can be very honest, when I was at the NIH doing my oral medicine training, we had to do clinical research as well, some sort of research. And the Sjogren's population, they had a very robust Sjogren's clinic there. And it was easy population to design questions and develop a research project. And so I came about it not through any really love or desire to pursue interests in Sjogren's. It just happened. But then, and that was that was more than 25 years ago. And it's become a true passion of mine over the years. I feel that the patients with Sjogren syndrome are very, very way underdiagnosed, and there is a huge need for people in the medical and dental profession to know more about this patient population and help service this patient population. And a couple of the things that really drove that point home to me personally is that I have a sister who has Sjogren syndrome. I have a cousin who was recently diagnosed with Sjogren syndrome. And my grandmother had a rheumatoid arthritis, had a couple cousins who had systemic lupus erythematosus. So there's a lot of rheumatological diseases that have been going on through my family. And I thought, well, am I unique in that my family's like this, or is this the norm? So I tried to look up some statistics on how prevalent the condition is here in Trinidad or in the Caribbean. And I will tell you, it's impossible to get those numbers. The numbers are just not out there. If you take a look at statistics in the rest of the world, it's also difficult to get those statistics as well. So we don't really know the true prevalence of this, but I can state firmly that the amount of undiagnosed patients is it really is not reflective in the numbers that are projected currently. And so with that, I'd like to make this as meaningful to you all as possible. And I want to kind of focus in on those top rheumatic diseases that I talked about, Sjogren's, lupus, and rheumatoid arthritis. Although I've got a lot of slides here. I'll skip through the other things because I want you to be able to, as a clinician, be able to identify patients who may have these problems and help to diagnose these patients if they do have these conditions, and also help to make the right referrals so that they can get properly diagnosed by the medical community, and then ultimately help to manage their oral symptoms that come along with their disease. And again, if I want it to be very meaningful to you, so if questions come up throughout my presentation, don't hesitate to just raise your hand, shout out the question. I want it to be, like I said, meaningful to you all. And so, so let's go in and we'll start off by talking about Sjogren's. Sjogren's syndrome is now more commonly in the literature being referred to as Sjogren's disease. You know, a syndrome is a combination of 3 or more characteristics, and it really downplays the systemic component of the features of Sjogren's. And so traditionally, what it was thought of as just a nuisance disease, dry eyes, dry mouth. So if your mouth is dry, so what? Drink more water, and carry on with your life. If your eyes are dry, maybe, you know, do some eye drops and just go on with it. But we find that it's a systemic disease. It's a systemic disease that affects the exocrine system throughout the body. And so although the eyes and the mouth are very easy to assess those features there, patients will have GI problems, they will have lung problems, they will have a great degree of fatigue, brain fog, neurological problems, and all of those symptoms are starting to come to light now. So it's a distinct systemic autoimmune disease, and the prevalence in the United States runs from about 1 in 1,000 to 1 in 10,000 individuals. It's said in the US it affects maybe about 1 to 4 million people. And so if you think about it here, I did some quick math. If you take a look at it's 1.5 million population here in Trinidad, you're probably talking about several hundred people who have Sjogren syndrome, and it's not to mention all the other rheumatic diseases that are going on there. And so it's been described as an autoimmune exocrinopathy. So the exocrine glands are being affected. And so if these lubricating glands are being affected throughout your whole body, it stands to reason that you'll have lung issues and GI problems that go along with these things. There's progressive loss of secretory function over time, and the typical age of diagnosis is around the 5th decade. But as people become more aware of the condition, what the signs and symptoms are, the age of diagnosis is lowering. So now we're getting people who were able to diagnose, just because we know what we're looking for, more in their mid-30s and going on up there. And so, and there's a lot of research now in the United States because of all of these new medications on the scene, biologic agents, things that target B cells and T cells, things at a very molecular level, that there's a lot of investigation in trying to identify these patients that have features of the disease way before 10, 20 years preceding their actual diagnosis. If you talk to a patient and you find out that their mouth has been dry, you ask them how long it's been dry. It's not uncommon for these Sjogren's patients to have had dry symptoms for at least 10, 15 years before they actually get to the point where they're looking for answers to help them with their problem. And so, and the other interesting feature about autoimmune diseases in all is that they affect women more than men. In Sjogren's syndrome, it affects women at a 9-to-1 ratio. In lupus, it's about a 6-to-1 ratio. And so, so there's something there, some genetic component that is contributing to the disease. I put this up because it just shows you that although it had been thought of as a nuisance disease, like I mentioned before, dry eyes, dry mouth, all these multiple organ systems are affected throughout the body. And so if we can focus in on the impact on the eye dryness, you got to think about it. It's more than just my eyes feel sandy and gritty, let me rub my eyes or put some drops. There's corneal damage that if it progresses long enough can lead to scarring and blinding of the eye. The oral manifestations, the oral dryness. Having a talk to you today, right now, I've had people who say they can no longer teach because they can't lecture to students effectively because their mouth is so dry. I've had basketball coaches that say they can no longer perform in that field anymore because they can't run up and down the court yelling out plays to their teammates because their mouth is so dry that even though they yell, they just can't be heard. And so it has significant impact on people, especially if they are public speakers and things like that, in their ability to function in a professional realm as well. So it's got tremendous impact on quality of life. If you think about it also, it's got tremendous impact on dental health. And so with less saliva, we all know, preaching to the choir here, that without saliva, patients are much more prone to progressive and rapidly progressive dental decay. And so that is meaningful to us because if we as a clinician go in there and fill a tooth, and you tell a patient you've got to brush and floss and take care of your teeth, and they say, oh, I'm doing it, oh, I'm doing it. With my patients, with my Sjogren's patients, I know for a fact that they are meticulous about their brushing and their flossing, but even at that, they still get recurrent decay around existing fillings and on the incisal edges of teeth and on the exposed cementum of their teeth because of this, because of the reduced saliva. The saliva helps to remineralize teeth. It helps to adjust the pH. And so it helps to wash away debris. And so if you've got all of those things coming together, these patients are much more susceptible to rapid decay. And then what does that mean to you as a clinician? Well, now they come in, you've just filled a tooth maybe a year ago, and now they've got recurrent decay around the margins of the filling that you've just placed. And so now you've got to remove the old filling, remove the decay, and put a larger filling in there. And so, yeah, it's good for business because you get to charge them more money. However, you're breaking your back because you're contorting yourself trying to chase the caries around the necks of these teeth that you're trying to restore in these patients. So it becomes very problematic for everyone involved. And so what I'm going to try to do is give you real life, hands-on, practical information on how to kind of identify these patients and how to help you manage their problems the best we can. And so, so let's go on. Let's go on and talk about diagnosis. Now, with Sjogren syndrome, we know, well, with a dry mouth, we know that there are multiple things that can cause dry mouth. And the most common cause of dry mouth is medication-induced xerostomia. It's dry mouth because of a side effect of the medications they're taking for other systemic diseases, blood pressure, diabetes, common diseases. You're taking these medications and it dries out the patient's mouths. These patients are different from the Sjogren's patients in that their ability to produce saliva is still maintained. So their salivary glands still function. In Sjogren's patients, they have an autoimmune infiltration, lymphocytic infiltration within the glandular tissue that makes the glands unable to produce saliva. And so that means something to you as you're trying to give them advice on how to manage their dry mouth. Because if you think about it, if the salivary glands are destroyed to the point where no matter what you give them, squeeze on these glands as much as you can, they cannot produce saliva, then what you need to do is start to prescribe for them or recommend for them artificial salivas, lubricants, sprays, gels, those types of agents to help manage their dry mouth. Whereas the patients with the medication-induced xerostomia, their glands function. It's the medications that's causing them not to make as much saliva in between meals. So with meals, they can still make saliva so they can eat their food and drink, or they can swallow without having to drink fluids, whereas the Sjogren's patients need to sip fluids to kind of help to get the food down. And so, so you will find that that with these medication-induced xerostomic patients, your management is going to focus on giving them things to help them stimulate saliva more continually throughout the day. And so the management in those patients fall in the realm of chewing on gums, sucking on candies, those types of things, so that you're stimulating the saliva flow more continually throughout the day. And of course, with that in mind, you want to make sure that it's sugar-free because you don't want them getting cavities while they're chewing all this gum and sucking on all this candy. And so, so the most important thing for you to do is when you're, if you do start off with a preliminary question to the patient, does your mouth feel dry? Do you feel you have to drink fluids frequently throughout the day? Is to then take a look at their medical history to see what medical problems they have. hypertension, diabetes, thyroid, those common types of things, and what medications they're taking to manage these things, because it could be a medication-induced xerostomia rather than Sjogren's. Now, if you take a look and they're not taking any medications and they're not, they don't claim to have any underlying medical conditions, then your suspicion for Sjogren's raises up a little higher in the list of possibilities. And so when that happens, when I do my workup for Sjogren's patients, what I do is I take a look at the oral features, the ocular features, and systemic features. Those are the three circles that we see over here. When we're looking for the ocular features, we're working sometimes with an ophthalmologist to see how dry those patients' eyes are and how many tears they're able to produce. So of course, the dentist cannot, we don't have slit lamps in our practices, so we can't take a look and put the dye stains in the eye to look at epithelial corneal damage there. But what we can do is do a Schirmer's test. A Schirmer's test is a little piece of litmus paper. You put it into the inner aspect of the patient's eyelid. And if you think about it, if I were to stick a piece of paper in your eye right now, what would happen? You would start to make tears. If your tear glands don't function, you can't make those tears. And so after 5 minutes, what you do is you measure how much wetness, how many millimeters of wetness there are on these little strips of paper. And if it falls below a certain cutoff, then it's objective evidence of ocular dryness. So that is a test that we can order those strips and then do that in the dental office, and we do that in our practice. For the dry mouth component, what we do there most commonly is assess their saliva function, whether they're able to produce unstimulated saliva and stimulated saliva. The important thing to do to keep in mind when you're assessing that is remember that saliva follows a diurnal variation. So the amount of saliva that you make changes depending on the time of day. And so what we do is we standardize our saliva collection to collect it before 11 a.m. Whenever we're doing these assessments or workup on patients. And so and it's very simple to do a saliva test, measurement test. You get a little bottle, a little vial, weigh it first. You have the patient sit there, swallow whatever's in their mouth. Whatever collects over 5 minutes, just have them drool, not spit, but drool into the cup. So we always close them in their own little door so that they're not embarrassed about drooling into a container. And we want them to drool, not actively spit, because the act of spitting actually stimulates saliva. So we want whatever's passively collecting in there to be drooled into this vial. And then after the 5 minutes, weigh the vial afterwards. And then you subtract the post collection from the pre, and you've got how much they've made there. And so if the UWS is unstimulated whole saliva, if it's below 0.1 milliliters per minute, then the patient has objective evidence of salivary dysfunction, low salivary flow. To get a sense of whether their salivary glands work or not, we also collect stimulated saliva. And so with stimulated saliva, what we do is we give them a little piece of paraffin wax, unflavored wax. Some people do citric acid flavored. And we have them, again, swallow whatever's in their mouth, start to chew on this wax, and spit again into a pre-measured vial, and do this over the course of 2 minutes. And this one, the act of chewing on whatever the product is going to help stimulate their saliva production. And then you can measure it and see if they're able to produce stimulated saliva, or 2, how much stimulated saliva there is. And that gives you a little idea of, like, are they able to function and how well are they able to function? And I find that very important, because if a patient is able to produce a good amount of saliva, the artificial gels, the sprays, the artificial sprays and things, lubricants, won't stick around in their mouth long enough. So they will put it in there, it'll last for 5 minutes, and then they'll say, oh, this stuff doesn't work. It only happens for, it works for 5 minutes because, you know, it gets washed away from my mouth. So that's why those patients who are able to produce saliva are not the best candidates for the artificial saliva or lubricants. They'd be the better candidates for the gums or the candies, the sugar-free gums and candies. And so assessing their saliva flow helps you to identify and select those patients. And then to assess the systemic component, the systemic involvement, there are two ways to do that. One is to look for autoantibodies in the lab, in the blood work in these patients. And we're looking for specifically Sjogren syndrome antibody A, SSA autoantibodies. And that helps with distinguishing Sjogren's from other nonspecific inflammatory disorders. There are other inflammatory markers that a rheumatologist would be looking at to assess whether they need to be placed on systemic immunomodulators. And that includes the ANA, IgG, erythrocyte sedimentation rate, CRP. Those are acute phase reactants. And if the inflammation is high, then that's when a rheumatologist might look at putting patients on different medications such as Plaquenil or methotrexate or some of the biologics that are on the scene and used commonly in the States. I don't know how readily available it is here in Trinidad, but there are some options that way to reduce that systemic inflammation. But the thing to remember about any of these systemic medications is although it reduces the systemic inflammation, it doesn't really reverse the glandular damage that's occurring in these patients. It may maintain the glandular function over time, but it doesn't bring back saliva flow. And so, so when I'm working these patients up, and so that's one of the things. That's a lesser invasive way, but more costly way, the lab testing. The other thing that we do is look for specific patterns of inflammation within the salivary glands. And that's a minor salivary gland lip biopsy. And I'm going to show you what that is maybe in the next slide here. Okay, yeah. So, so the minor salivary gland lip biopsy is a surgical procedure, and it is a little bit more. It's more invasive than just a venipuncture to draw some blood, of course, but it is something that you can do in your practice, and send it off to pathology and see if there is little clumps of immune foci, which I'm going to show you in just a moment. You've got 4 major salivary glands, parotid glands, submandibular glands. And in addition to that, and they give you about 90% of your saliva. In addition to them, you've got about 750 of these minor salivary glands that are distributed throughout the mouth. A bunch of them are just on the inside of the lower lip. So if you run your tongue very lightly on the inside aspect of your lower lip, those little lumps and bumps right below the surface are the minor salivary glands. They're pretty superficial. And so I select the side of the inner aspect of the lower lip that's not traumatized. So if a patient bites their lip or just had, you know, curry goat last night and bit their lip or something like that, you want to avoid those areas of injury and go to a non-injured area when you're selecting your site. I use a Chalazion clamp. This little clamp here is used in ophthalmology a lot, and what it does is it helps to put pressure in the area that we're working on. This is after I've anesthetized the lower lip. I've done local infiltration into the site that I'm going to retrieve my specimen from. I put the clamp on there. It helps to compress the blood vessels so it keeps the bleeding down from the local area. And then I make a 1 centimeter long incision. These glands, like I said, are very superficial. So if you see here, the projection may not show up as well, but those little lumps are those little clumps of the minor salivary glands. And then I blunt dissect them away from the surrounding connective tissue, blood vessels, and nerve bundles there. We collect about 4 or 5 of them. This is a whole bunch of them. They come out sometimes like a little clump, like a little bunch of grapes. And so you want to remove the whole clump, because if you leave back an injured minor gland, then the patients may develop a mucocele, and then you'll have to go back in there and do a second procedure. So you remove the entire gland, and that's why you'll see so many of the lobules here. That it's really only about 2 or 3 glands, several lobules, but 2 or 3 glands. And then we send them off to the pathologist. The pathologist, of course, they prep it, they slice them real thin, and then what they're looking for under the microscope are these little foci that are 50 or more lymphocytes in a perivascular or a periductal arrangement. And they have to quantify how much tissue specimen you've given them, and they're counting and they're giving you an average of the number of these clumps within a 4 millimeter square field. So that's why you need to retrieve about 3 or 4 of these minor glands when you do your biopsy. And if a patient has a focus score of 1 or greater, then that fulfills criteria for Sjogren syndrome. And so why is this important? Well, a subset of these Sjogren's patients will go on to develop lymphoma. And lymphoma is cancer, it's life-threatening. It's not a huge number of these patients, but it is up to about 5% of these patients over the course of 5 to 10, 15 years that may develop lymphoma. And so that's why it's really important to diagnose patients with Sjogren's and then follow and manage these patients with Sjogren's. And I can tell you what to look for to see for signs and symptoms of the development of lymphoma. We're going to get there in just a minute or two. And so, so that's why that's the value of doing these minor gland biopsies on patients that you suspect has Sjogren's. And so, so again, now that you've got a patient and they've been diagnosed, at this point, then I start working with the rheumatologist to help assess the systemic components, see if disease-modifying anti-rheumatic drugs have to be prescribed, and they manage the systemic component, and then I manage the oral component, and then the ophthalmologist manages the ocular component there. And so it really takes a team of players to help manage these patients medically as they go through. The eye treatments, there are more and more medicated eye drops that are out there that's helping to reverse the corneal abrasions and irritations that are damage that's happening in these patients. There's Restasis on the market, a few other ones. I don't know how readily available they are here, but artificial eye drops, lubricants, and those types of things are used to manage that. We talked about the symptom relief orally. I talked about the gels, the sprays, the gums, the candies, lozenges. The most important thing is make sure that it's sugar-free because you don't want these patients developing rampant caries as they're managing their dryness. And then if these agents really are not sufficient, then what I do is I go to the parasympathomimetics. There are 2 medications that stimulates the parasympathetic nervous system. And we know that the parasympathetic nervous system is responsible for saliva production and also sweat production and GI fluid production as well. And so it's important to keep that in mind because these medications have systemic side effects associated with it and sometimes limits the patient's abilities to take these drugs. And so with these medications, they are also short acting. They're in the blood for about 4 hours or so. However, the therapeutic window, the time that patients feel relief from using these things really ranges on the order of 1 to 2 hours. And so for that reason, you have to take these medications several times throughout the day. And so, and it's pretty costly. So, and I don't know how readily available. Has anyone ever had to prescribe this here? Yeah, I don't know how readily available it's going to be for you to get these, but if they travel to the States, maybe they can get care over there. And then you can also educate your patients to what to ask for if they do travel other areas that they may have easier access to some of these treatments. And so, yeah, so pilocarpine is the one that's been on the market for the longer period of time and is a little less expensive. And then the cevimeline is dosed 3 times a day, pilocarpine 4 times a day. And cevimeline is reported to have less systemic side effects, but in my clinical experience, the side effect profile is pretty similar for both of these medications. And so, so that's going to help with the dry mouth components and quality of life and speaking and eating and talking and those types of things. Caries management, imperative that you start them on high dose, high concentration fluoride. And so, you know, your regular Crest and Colgate, that's on the market. It has like 1,000 parts per million fluoride. This Prevident is 5,000 parts per million fluoride. And again, I think it's available. It might be available over the counter here. You can get it over the counter in the States now too. I instruct patients to use this once a day at night, just before they go to bed. So it should be the last thing that they do. With these patients, I told you, you tell them to brush and floss. You think maybe they're lying to you, but they really are brushing and flossing multiple times throughout the day. I have them use this product just before bedtime because I want the most amount of contact time with the fluoride and the teeth. And so the way I instruct them to do this is after you brush your teeth and you rinse your mouth out and you spit, then put a little bit of this product on your toothbrush, apply it to all the tooth surfaces, spit, don't rinse your mouth out, and don't eat or drink anything after that. Just go to bed. So this way, again, you've got the most amount of contact time with the product, with the fluoride to the teeth. And of course, they can use their regular toothbrush the other times a day that they're brushing their teeth. So that's fine. We also have, I don't know if I have the thing here. We also have other remineralization products in the States. One is called MI paste. It's a phosphorus paste that has a whole bunch of components that helps with remineralization of teeth. Now, I'll have patients use that MI paste at the beginning of the day and then this Prevident at the end of the day because it becomes very cumbersome. You want them to not eat or drink anything for several minutes afterwards, and it's sometimes a little hard for them to coordinate everything. So I'll have them separated out like that. Another thing with these patients that I want you to keep in mind is because their mouth is so dry, they're not able to clear organisms from the mouth. So the bacteria count is very high, and then the yeast count is very high as well. So these patients are much more prone to getting oral fungal infections and or oral candidiasis. And oral candidiasis, it looks very different in a Sjogren's patient than it does in an immunocompromised patient. If you think about a patient who's getting chemotherapy for cancer, they have that curd-like pseudomembranous candidiasis that's distributed throughout the mouth, the oropharynx. In Sjogren's patients, they may not have that curd-like appearance. What they do have is the tissue irritation. So they present with erythema, edema, burning sensations on the tongue, the insides of the cheeks, roof of mouth. They will also have sometimes complaints of malodor, and they'll have maybe sometimes a slimy texture in their mouth. And so you want to ask them about all of those components and assess whether they've got oral candidiasis or not. And if they do, we treat them with an antifungal medication. If you do treat them with an antifungal, the nystatin rinses, which are readily available, have a high sugar content. And so if you're going to put them on the nystatin for a long period of time, be mindful that it increases their caries rate because of all the sugar in there. For that reason, I like to put patients on a systemic antifungal. I find that compliance is much better. Instead of a 4 or 5 times a day dosing with the topical agents, it's 1 time a day dosing for a 2-week period of time. So my preference is systemic fluconazole. Another option would be the clotrimazole troches and those types of things. But I also caution you that if a patient is unable to make saliva, the reasons those lozenges work is that they dissolve in the saliva and they bathe the oral cavity. And so if you can't dissolve these medications, they're going to be less effective. So keep that in mind as you're selecting your antifungal medication. Any questions on any of that? Is it something you guys think you might be using in practice or maybe able to apply to the patients that you treat? All right, good. Because again, I want this to be something you can translate into clinical care for your patients when possible. These patients also, because they're not making a lot of saliva, it's not coming into their mouth as readily, they are prone to getting infections of the major salivary glands, purulent discharge. And that's what we see coming out of the Stetson's duct over here, purulent discharge over here. And for these patients, they'll have to be placed on systemic antibiotics to clear that infection. I'll also tell these patients to hydrate themselves properly. You would be surprised how many patients don't drink enough water. And something as simple as making sure that they drink 64 ounces of water throughout the day can make a huge impact on them orally and systemically as well. And so if you're squeezing on these glands to try to get more saliva out, if there's not enough moisture in the body, nothing's going to come out. So make sure that they're properly hydrated. And then I have the patients massage their salivary glands because the infection develops in these salivary glands because of the stasis of the saliva within the glands. And the bacteria go in a retrograde fashion from the oral cavity into the glands, and then they multiply, they propagate. And so what you want to do is you want to flush out that infection. Even if you put them on antibiotics, if you don't flush the infection out, it just takes that much more longer for them to get over this oral infection. And so, so what I do is I tell patients to put one finger behind their ear, because you know that's where the tail of the parotid is, one finger in front of their ear, because that's where the body of the parotid is, press down and go to about mid-cheek. And that's all they have to do. The best time for them to do these the salivary gland massages is just after a meal, because that's when we produce the most amount of saliva. And so I have them eat their meal, whatever it is, do 4 or 5 passes in those in the submandibular, the parotid glands. Submandibular glands are just below the angles of the mandible, so up and forward. And if they can do that 3 times a day, that's going to help to flush the saliva out of the glands and help them to get over these infections faster, and also help them to prevent the onset of another infection in the future. And so, so that's what I would do for those patients. Any questions? All right. So, so let's go on and talk a little bit about rheumatoid arthritis. Another reason why I think that rheumatoid arthritis is important for the general dentist to know and be aware of is because these patients have a lot of features that overlap with the features of Sjogren's. These patients with rheumatoid arthritis will have joint pain, they will have fatigue, they will have morning stiffness. Morning stiffness is not such a problem with the Sjogren's patients, but it is a problem with these patients who have rheumatoid arthritis. But they also have, they get their joints, and especially in their hands, deformed. So simple tasks like holding a toothbrush and brushing their teeth becomes difficult for patients if they don't have the dexterity in their hands. And so what I will do for those patients is I'll modify their toothbrush. So I'll get something like duct tape or bunches of rubber bands, and on their regular toothbrush, just put a bunch of those over the handle of the toothbrush, just so it's thicker. So if the patient can grasp the toothbrush a little bit easier, they can brush their mouths a little bit better. And so that's an easy fix for some of these patients with rheumatoid arthritis, osteoarthritis too, if they have joint deformities associated with that. And it'll help them to better manage their oral hygiene throughout the day. And there's also, you may have heard of secondary Sjogren's. So we're trying to get away from that classification of primary Sjogren's and secondary Sjogren's, secondary Sjogren's historically has been Sjogren's associated with another autoimmune disease. And so I gave you the rundown of the autoimmune diseases in my family. It's not uncommon for patients to have more than one autoimmune disease. My sister, in fact, was diagnosed with lupus first and then developed Sjogren's afterwards. And so the features of these autoimmune diseases really change over time or can change over time. And so, with rheumatoid arthritis patients, again, age of diagnosis a little bit lower than that of Sjogren's, about mid-30s is when they're typically diagnosed to about 50. Females affected more than males, 3-to-1 ratio, and it affects about 1% of the population in the United States. You can see here when I talk about the deformity of the joints in the hands, you can appreciate it's very difficult for this patient to pick up a toothbrush and perform her oral hygiene. And so any kind of aids or modifications you can do to help the patients would be very much appreciated on their end. Now, with these patients, what I wanted to point out is that, again, I wanted to give you the oral presentations, the head and neck presentations that can be of concern to you as a providing dentist, is that the joints in these patients, differing from osteoarthritis, is erosive erosions within the joints. It's not a bone on bone; it's an erosive thing infiltrating the bone itself. And so you do, when it does occur and it happens on the condyles, you do get eventually flattening of those condyles. And then these patients go on to progressively develop an anterior open bite. And so, so that becomes a little problematic. And this is a patient with juvenile rheumatoid arthritis. And we find it happening more in the juvenile population, less commonly, and not that it doesn't happen in the older patients, but it really is evident prominently in the juvenile population here. And so this patient, you can see up there, only has occlusion on the posterior teeth. And that's purely because as the condyles erode, the jaw goes inferiorly and anteriorly and in response. And so those are a couple of the manifestations, oral manifestations that I find important for the dentist to know in these patients. The other thing that's very important for us as if we're going to do any kind of dental surgery, extractions, cleanings, periodontal surgeries, biopsies, is that they're taking medications to manage their pain. And these pain medications fall within the realm of NSAIDs, anticoagulants, and antiplatelet medications. And so, so you really need to be mindful of the increased risk for prolonged bleeding when you're doing invasive procedures in patients who are taking pain meds for their joint problems in this patient population. And then the last disease that I want to go over is lupus. And the reason why I think it's important for us as dentists to know about lupus is because lupus is the diagnosis of lupus, as in Sjogren's, is not made just on one feature. It's not made on just one lab finding or one clinical finding. It's a combination of about 11 to 14 different things that they're looking at. And patients have to fulfill, I don't know what the current things are, it's 4 out of these 11 findings. But I do list over in this next slide the findings that they're looking at of these 11 to 14 findings that occur within the head and neck field. They're looking for that butterfly rash, that malar rash. They're looking for oral ulcerations, oral lichenoid ulcerations. So here we're looking at the buccal mucosa, and we see erosions, frank ulcerations, and some Whitcomb stria-like lesions, lichenoid-like stria along the periphery. So those oral and nasal ulcerations is another one of the features that can occur in the head and neck that leads to the diagnosis of lupus. The other thing that comes into play in the diagnostic criteria for lupus is hair loss, alopecia, patchy hair loss. It's not just, thinning male pattern baldness. This is patchy hair loss in a specific pattern. And as you're doing your head and neck exam, that's totally within our field to pick up findings, features associated with that. And photosensitivity. Photosensitivity is a rash that develops on the sun-exposed areas of the body. And so if, and some of my lupus patients, they have to wear gloves when they're driving a car, because if you're holding onto the steering wheel, the sun is coming in and they'll get a photosensitivity reaction on their fingers. The sun is coming in the States, it's coming in on this side of the car. It's coming in on the right side here, coming in through the window. And so they'll develop the photosensitivity reaction on that arm and not the other arm. And those are things that you might be able to pick up on your clinical exam from these patients. So that's why I just wanted to review what those oral findings are, because again, you might be the first person who picks up signs and symptoms that you can bring it to the attention of the patient, and then they can let their physician know, because lupus, especially systemic lupus, if there's kidney involvement, that could be deadly. So patients can die because of this autoimmune disease here. And so we can be a very, very big player when it comes to diagnosing these patients in our population. And so the other things that you would want, so I don't know what you guys do during your intake, your health history intake for patients, but you might want to take a look at the forms and just add a couple questions to these forms. Does your mouth feel dry to you? Do your eyes feel gritty? Have you had mouth or oral ulcerations? And even if they were to just answer those 3 screening questions, that might help you to identify these patients that might fall into these categories. And then you can widen the area of investigations questions depending on how they respond to those screening questions. And so, when you're managing these patients with lupus, the things that you have to be aware of, if they're already diagnosed, they may be on immunosuppressant medications. And if they are on immunosuppressant drugs, they're at increased risk for infections. And so what does that mean to you? Well, if you have a patient who has a dental abscess, instead of just pulling the teeth and just and knowing that if the tooth is the source of the infection, getting rid of that source is what you would do in a healthy individual. In these patients who have a compromised immune system, they might have delayed wound healing and get an infection within the socket after the extraction. So you may have to put them on antibiotics after your dental procedure. And so also these patients are also at risk for fungal infections as well. And you want to look out for the signs and symptoms that I had described earlier, not the cottage cheesy kind of things. Well, sometimes they present that way as well, but they might have more of the burning sensation, the edema, the erythema, the bald tongue, the fissured tongue, and those types of things that you'll find on clinical exam. And then a significant amount of these lupus patients are on blood thinners. So the increased risk for bleeding is definitely a consideration for them as well. And so with that, I know that our time is getting a little bit down to the wire here. So what I want to do is just skip down a bit and go over a case with you. So this was a 48-year-old female who'd come into my practice, and her chief complaint was, over the past few years, to about 2 years or so, I've been getting these bumps on my lips. These bumps, they occur, I kind of pick at them, and they'll crop up. In the past year or so, I've had about 8 episodes in the last year. They usually resolve after about 3 to 7 days. And about 2 years ago, I went to my dermatologist, and my dermatologist gave me this tube. It's called Protopic, which is a calcineurin inhibitor. It's an immunomodulating drug, topical cream. And so when she would get these bumps, she would put that protopic on her lips, and these things would heal up after about a day or two, and then she'd go on living her day, and then she'd get another crop of these things happening several weeks later. And the only reason she came to see me was because that one tube of Protopic lasted her for the full 2 years. And she was getting down to the very last dregs, and she was like, "Can you just renew this prescription for me?" And so I was like, "Well, let me just ask you a few more questions as we go along here." So her medical history was unremarkable. No systemic diseases, never smoker, doesn't drink alcohol, no recreational drugs. On review of systems, she did say she's got quite a lot of fatigue lately. And when she took a picture of her lips 1 week or 2 weeks before she came to see me in the clinic. So if we take a look at her lips, they are plump. They're a little swollen. And there are these little, if you could, the resolution on the slide that she gave me too, the picture is not that great. It's a little out of focus, but small, tiny little bumps that are up on the border of the lip here, upper lip and lower lip. And you can see that the vermilion border here and the the vermilion border is blunted. So there is swelling there. So it's actual edema. This is what she looked like when she saw me. So she does have cracks at the commissures of the lips, splotchy redness. Her lips are still a little swollen here. And she does have 1 or 2 of these little bumps that she had described getting frequently in the past. If you take a look at her hard palatal mucosa, it looks very erythematous, and again, splotchy. If you look at her tongue, although you see a little bit of the reflection of the flash there, there's absolutely no saliva in her mouth. It's fissured, and there's loss of filiform papilla on her tongue. When we took a look at her salivary glands, again, there was a purulent exudase coming out from the parotid glands bilaterally, and she never, in all of my history of her, ever stated that she had dry eyes or a dry mouth or that she had joint pains. I did get a little history of fatigue from her. And if you also look a little closer, she's got a lot of plaque that's accumulated on the margins, gingival margins of her teeth here. If you take a look at the floor of the mouth, no salivary pooling at the floor of the mouth. We've got incisal, we can see a lot of composite restorations on all of the interproximal areas here. And we've got recurrent decay in incipient decay here and recurrent decay around the margins. So, what does she have? Thoughts? Sjogren's. That's what I suspect. Well, number 1, diagnosed her with intraoral candidiasis. She had angular cheilitis, candidiasis at the commissures of her mouth. She also had a parotid gland infection. She has dry mouth, and she has increased caries. And so what I did for her was I put her on a systemic antifungal. I also put her on Mycolog cream for the commissures of the mouth. Instructed her to apply that 5 times a day. Told her to massage those glands for exactly the reasons that we went over earlier. Increase her water intake. I think she was only drinking 1 or 2 glasses of water throughout the day. And I asked her to chew on sugar-free gums, suck on sugar-free candies, and gave her pilocarpine. I also gave her some topical fluoride to use at night, and we ordered some lab tests for her. When she came back, you can see the before and then the after. Although it may have been hard to see the lip edema and erythema and swelling and inflammation previously, you can see the dramatic change in the after picture here. Hard palatal mucosa, when it's side by side, you can see healthy and pink in the post, really red, inflamed edema, edematous in the pre. And again, you know, Candida in a dry mouth patient does not look like this. This is what you'll see in a severely immunocompromised patient. Candida in a dry mouth patient looks more like this. And this is what her tongue looks like before. Edematous, red, beefy, fissuring. Here, more healthy pink. She's starting to get the formation of the filiform papilla again back on the dorsum of the tongue. And her lab results showed that she was very, very highly positive for SSA autoantibodies. ANA was positive. Speckled pattern is found in Sjogren's patients as well. We also ran some tests to rule out lupus, and all of those were negative. Actually, I think she had, no, that's SSB. So she did not have features of lupus there. And so we were the one who diagnosed. We got her in touch with a rheumatologist that put her on systemic immunomodulating drugs, and we managed her dry mouth, and we worked with her dentist to help manage her caries as well. Another case here, we'll go over this one just very quickly because I think this is important. We talked about lymphoma. This is a 73-year-old retired dentist. He came in with complaints of swelling of the right neck, and he had a history of being diagnosed with Sjogren syndrome many years before. And so now he's got this swelling in the neck. And remember what I said, patients are at risk for developing with Sjogren's is lymphoma. Well, what we do is during our head and neck exam, we feel for lymphadenopathy, and he had lymphadenopathy going on there. So patients with Sjogren's can also have salivary gland enlargement that's cyclical, comes and goes. It's sometimes hard to find out whether that salivary gland enlargement is lymphoma or salivary gland enlargement with Sjogren's. The thing about lymphoma is it's enlarged and it's persistent and it progresses. And then you put that together with other constitutional signs and symptoms such as fever, night sweats, unexplained weight loss, and those types of things. And those are all signs and symptoms of lymphoma going on with this patient. So again, we got this patient in with their primary care doctor and then oncology from there, and help to manage this patient as well. And so we're a little bit over time right now. Thank you for bearing with me here, and happy to take any questions if there are. Thank you for being such a wonderful audience. Any questions? Um, Fluoride rinses will help. There are what's it called? Listerine now has fluoride in their mouth rinse. You have to make sure, not all of their Listerine products do. You have to make sure that their mouth rinse does have fluoride. And if it does, get them to use that twice a day. Yeah, great question. Absolutely. Use the regular fluoride toothpaste the best that they can as well. They might want to also rinse with baking soda rinses because that helps to get rid of the acidity within their mouth. So that might be beneficial for them. And beyond that, then sugar-free gums and candies. Because again, the more you can stimulate their saliva throughout the day, the healthier it's going to be for their dentition. Great question. So the question is there any difference in how we treat the radiation-induced xerostomach patients? And the management is very similar to the dry mouth caries management that I'm doing here. Another thing that we do is for your child population, do you do the fluoride treatments in the clinic? So what we'll do is we'll make custom fluoride delivery trays, and we'll give them that product to go home and use with at night there. And those trays are great because you put them in place, you leave them for 10 minutes or so at night, and it's just concentrated fluoride application. Do you have fluoride varnishes available here? So fluoride varnish, with my Sjogren's patients and my radiation-induced xerostomia patients, every 3 months, they're coming into the office and I'm placing the fluoride varnish. And you really have to make the patient really understand how rapidly the decay can progress, especially in the radiation-induced xerostomic patients, because they can go within 6 months from full teeth, no problems whatsoever, to every tooth has to be extracted because of the decay is so, but it doesn't have to be that way. I can show you pictures of before and after too of adherence to the protocol and lack of adherence, and 3 years later, maybe one tooth had an endo and was able to maintain all the rest of the teeth. Great question. Yes, please. The question is there any advantage of the biopsy to the blood tests? I forgot to mention when I was telling you that neither one of these tests is 100% diagnostic. Otherwise, it would be just one test that we have to do. I usually do the blood test first because it's less invasive than cutting into their lip. And, but that's only positive in about 60% of the cases. If it comes back negative, then I follow up with the minor gland biopsy. And the minor gland biopsy's got low specificity, a lower specificity rate. So you can get a focus score of 1 in patients who don't have Sjogren's. So that's why I don't jump into biopsies all the time. However, the one benefit and advantage that the lip biopsy has over the blood test is that if you've got a focus score, the higher the focus score, the more the lymphocytic infiltration. And that puts those patients more into the high risk of developing lymphoma category. And so sometimes you can also see germinal centers or diagnose a multiple lymphoma just from the lip biopsy. And so that's the really big advantage that the lip biopsy has over the blood test. Great question. I love that. Yes. I am I really, really want to design a study where I can test that in the Sjogren's patients because, again, restoring these teeth is so hard for you all, and it will. I think there have been smaller case studies that have looked that they're tremendously effective in arresting decay. Of course, they don't look beautiful, and so so for posterior teeth, you may want to use it, but I think it's a great option and alternative for these patients to manage their caries. So the question is, what's the antibiotic of choice for patients with salivary gland infections? I go with amoxicillin first line. And the reason why I do that is because most of the time it's retrograde bacteria from the oral cavity. And we know that amoxicillin is the most effective narrow spectrum antibiotic we can use for that. Now, if a patient does not respond, then I'll do a culture insensitivity. And I've had to put patients on, I've had couple patients that had a hard time with persistent infection and had to put them on doxycycline for months. And so it all depends on how responsive they are to first line and whether I change it. But then I'll follow it up with a culture insensitivity if it doesn't respond, knowing that I probably have to put these patients on the amoxicillin because they're so dry for at least a month instead of just a week or 2, and then assess for response after that. All right. It's really a pleasure speaking to you guys. Thank you so much.
Dr. Sankar, thank you very much for sharing your knowledge with us. And the students, I really enjoyed your enthusiasm on the topic. So on behalf of the School of Dentistry and the Dental Fraternity of Trinidad and Tobago, thank you very much. And we have a little token for you. And Candy will present.
Clinical management. And I know our students would have appreciated and understood why, and now understand a little better why we emphasize things like review of systems in the medical history and picking up that's the whole picture of the patient. So you could pick up these rheumatic diseases. So thank you again. A special thank you to our sponsor, TGC. And to Dexter Superville from CMSE, Marlon from IT, and a big thank you to Denley Leben as well for helping organize this evening.
Thank you very much.
All right, folks, you're invited to step outside. We have some refreshments outside. And with the staff of the dental school, please come forward. Dexter would like to do a group shot with Dr. Sankar. Oh, can you come once a year?
Well, I come every